Hi, everybody. Good morning. This title is not mine, right? It came from this course development. How many of you have to order or use cell-free DNA testing? That's what we're going to talk about for an hour. Okay. Well, for those of you who do, I think there's some insights that I think will be really helpful today. And for those of you who don't, I think you'll learn something. Okay, so here are the objectives for today. And the only conflict of interest I have is that I have a research project that I'm doing with Progenity Labs, which is a cell-free DNA company, and they donated their technical expertise to my project. So for a lot of the topics today, I wanted to just use my favorite definition of screening, which was written by Nick Wald a long time ago, where he said that the definition for prenatal screening among apparently normal pregnancies of those at sufficient risk of a specific fetal disorder to justify subsequent invasive and or costly prenatal diagnostic procedures. So really what this says is that prenatal screening is different than other kinds of screening. You're taking a normal, healthy woman and you're trying to find out if her baby has a genetic disorder. And that's a little different than normal screening for women, you know, where we screen them directly for glucose testing maybe, or pap smears for cervical cancer. We're screening women for their babies. So just a little bit of background. In 2007, the American College of OBGYN said all women should be offered all forms of diagnostic testing and screening. And really what they mean to say here is that it's paternalistic to say, you're 35, we're going to offer you a diagnostic test like amniocentesis. You're under 35, you get a screening test. These guys said, that's kind of paternalistic. Everybody has a right to any test. And most insurers will cover, actually, any genetic test. Though we'll talk about that with its application to cell-free DNA in a few minutes. Just basically the differences between testing and screening, of course, is that diagnostic testing gives you a definitive answer, a yes or no of what's going on with your baby. Screening really lumps women into a high or a low risk category and doesn't give you a definitive answer, but it's usually not very costly and low risk to the woman. And so we use cell-free DNA screening the majority of times for aneuploidy screening. And to just hone down the aneuploidy box is to say that aneuploidy isn't related to your race or your ethnicity, that the general incidence of an aneuploid pregnancy is about 1 in 150 births, and that aneuploidy is due to meiotic non-disjunction. That is, during conception, an extra whole chromosome is in the cell, and so the baby has an extra chromosome. And when that happens, hundreds of genes are added to the fetus, which usually results in a non-viable pregnancy, sometimes results in a viable pregnancy, most often miscarriage or stillbirth. There's lots of ways to screen for aneuploidy during pregnancy. Age, ultrasound, blood tests like quad screens or integrated sequential screening, nuchal translucency screening with or without serum markers, and of course cell-free DNA testing. To compare cell-free DNA testing to standard aneuploidy screening, there are basically two kinds of aneuploidy screening. One is a one-test experience where a woman in the first trimester or second trimester has one blood test and gets a risk for aneuploidy. The more sophisticated analyte screenings are two tests. So a woman will have a test in the first trimester. She may or may not get a result from that test, have a test in the second trimester, and that combination of factors with her age and her race and her weight will calculate a risk for aneuploidy. And in general, the serial tests are better tests for aneuploidy than the single tests that we use. For years, people have said, well, you're high risk if you're over 35, and you know, one of the missions today is to tell you that that really isn't useful anymore, that age is really a continuum and risk is a continuum. If you only use age as a screening marker, understand that about 80% of kids with Down syndrome are born to women under the age of 35. Why? Because they're screened less effectively, and also because those women have more babies. So that you're missing most women if you just say, well, we're only going to screen women who are over 35 years old. We just don't think that's a valid way to screen patients anymore. When you compare the serum screening test with cell-free DNA screening, this, of course, is all a big setup to talk to you about cell-free DNA screening. You can see that cell-free has about a 98% detection rate for Downs, with a really low 0.5% false positive rate in high-risk women. And we'll talk about the difference between screening high and low-risk women, too. But you can see how powerful this test is, at least for Down syndrome. So, to talk about cell-free, first of all, what do you call it? And yes, so those are all terms. They're essentially interchangeably used for cell-free DNA testing. The ones on the bottom are what commercial labs are calling these tests. And there's 4 laboratories that perform cell-free DNA screening. Some other labs send out to one of these original labs, but because of patents, there are really only 4 labs that are actually doing these tests right now. These other terms, cell-free DNA, cell-free fetal DNA, non-invasive prenatal testing or screening, they're all sort of interchangeable. At ACOG, we've changed from the non-invasive prenatal testing term to cell-free DNA testing, or cfDNA, only because we think that's more specific for actually the test we're doing. Non-invasive prenatal testing could be ultrasound. So we've tried to be a little more specific with that. Just like in most national organizations, we wouldn't use one of these other terms from the commercial labs, but they're all essentially screening for the same thing. And they all use somewhat different techniques, but basically have about the same detection rate. We'll talk about that in a minute, too. We're standing here, it's 2015. This test is well integrated into medical care now, and this is 4 years since it was introduced in October of 2011. So for years, the holy grail, I think, of prenatal diagnosis has been the idea that you could test fetal cells in the maternal circulation. And so tons of research and money and investigation has gone into that. But actually testing cells is really hard. There aren't many cells. And cells persist. So if a woman delivers a male fetus and she's pregnant with a baby that's a girl, you might get male cells in there because those cells persist. And in 2008, Dennis Lowe in Hong Kong was actually working on cancer patients and fragments of DNA that was floating in patient circulation, and thought, wow, I wonder if I can apply those cell-free fragments to screening women for aneuploidy. And he wrote this paper in 2008, and a bunch of venture capitalists basically got together and did several studies. None of it was funded by the NIH. None of it was funded in an objective way. It was really only funded by companies. One was overseen by Brown University, but basically they were all done by companies. And then it was directly marketed to the public. And so for us in the prenatal world, this was the first time we had to grapple with a test that really had no objective validation from anybody who wasn't a dog in the fight or an investor in the fight, which was actually somewhat difficult. And even to this day, there's a lot of competition between these companies. They're all suing each other. They don't collaborate. They don't talk to each other. So it's true. So when one of them comes in and says, my test is better than the other guy's test, I'm here to tell you I don't actually think that's true. They use different techniques. Some are better for some things than others. But I think the take-home is they're all good tests. They all work essentially the same, and nobody has any special bells and whistles that's all that great. So what is cell-free DNA? It's basically 200 base pair fragments that are floating around in maternal serum, if you're talking about aneuploidy screening. And those fragments are both maternal fragments and fetal fragments, and the majority of them are maternal. So about 10% of cell-free DNA is actually fetal fragments that are floating around. And they're actually not fetal, they're placental fragments. So the placenta is like a proxy for the fetus. You know, everybody starts from one cell and kind of develops. Sometimes the placenta isn't exactly the same as the fetus because genetic changes can happen to the placenta. But in general, when we talk about cell-free fetal DNA, it's not fetal, it's placental. And that's why we don't use the term cell-free fetal DNA. We just use cell-free DNA because it's really not describing fetal material exactly. You can obtain a sample for testing for aneuploidy at about 10 weeks of pregnancy or later. You can actually find fetal fragments at about 7 weeks, but they're not that accurate and there's not that many of them. A blood draw to do a test like this, so no risk for miscarriage. And the fragments are undetectable by about 2 hours postpartum. So the volume of cell-free DNA increases during pregnancy pretty linearly through the second trimester and then kind of flattens out. And then after a woman delivers, it vanishes. So you're not testing her last pregnancy like you would do with cells. You're just testing the current pregnancy and basically at any time in pregnancy. Most conventional analyte screens you can only do till about 20 weeks or 22 weeks. So if you had a woman who had an abnormality that, say, suggested Down syndrome and you wanted to do a test because she didn't want an amniocentesis, you could do that at 32 weeks. You can't do a serum screen at 32 weeks. So there's 3 different, and I'm not going to spend much time on the lab techniques, but there's basically 3 different techniques that are used to come up with these fetal sequences to tell the baby's genetic makeup. They all work a little bit differently, and as I said, I'm not sure it totally matters the kind of laboratory testing they do, but massively parallel shotgun sequencing, or what we call next generation sequencing, means that get a blood sample and then you amplify hundreds of thousands of tiny pieces of DNA, tag them to figure out which chromosomes they're from, and then basically you count them to see how many copies you have per week of gestation. And that's different than sequencing, which tells you which actual piece of the chromosome you're looking at. Massive parallel sequencing is just a huge replication of genetic material with minimal tags to figure out what chromosome they're from. But it's not looking at every little piece of the chromosome DNA. So what happens is, for a baby who's got an extra, say, chromosome 21, they look per week of gestation, they have a volume that they expect per week, and if you have too many copies of 21, you're over some cutoff, you're called screen positive for something like Down syndrome. That's basically all they do. There are some labs that do single nucleotide polymorphism arrays where they look at more in-depth reads of the chromosomes. They're still essentially equivalent. There's a company that just does kind of a combination of both. As I said, they're basically equivalent. They have some bells and whistles. I don't think it really matters. And cell-free DNA, we're talking about aneuploidy today, but there's actually a lot of uses for cell-free DNA. In Europe, it's the primary test that's done to test an Rh-negative mother to see if she's carrying an Rh-positive fetus. In the United States, we do blood work for that. We see if the mother has antibodies against a baby. But if the baby's got the D antigen, got an Rh-positive gene, and the mom is lacking that, you can test from cell-free DNA to see if the mom is carrying an Rh-positive baby, and that changes her care. Sometimes we want to do testing like this for X-linked disorders. So if a mom is carrying a boy who's got hemophilia, and we can test for that, her obstetrical care is different, right? So we don't use forceps on someone who has a risk for bleeding. We don't circumcise a kid after birth. We give them factor VIII when they're delivered. We do other things to sort of protect the baby from a bleed inside of its brain. So knowing what sex a baby is actually quite important, and this test can be used for that. There are case reports, this isn't done in general practice, that if you have an autosomal dominant disorder, so dad has neurofibromatosis and you know what gene it is, as long as it's the dad, you can test the fetus. The fetus has a 50% chance of having that disorder, as long as the mother doesn't have it, because remember, with cell-free fragments, you can't really tell the mom from the baby. If the father has a disorder and you know what the disorder is, you know what the genetic mutation is, there's plenty of case reports now that you can test the fetus to see if it carries that mutation. If you wanted to do prenatal diagnosis that was non-invasive. And no one knows how good that is because it's really at the case report stage, but that is for sure next. We should be able to sequence a piece of the fetus that's different from the mom using this technology. And some labs will be better at it than others for this kind of testing. For straight aneuploidy, again, I don't think it matters. For stuff like this, it actually will matter. When you screen a baby for cell-free DNA abnormalities, this is the laundry list of stuff that you might be able to screen for. So standard aneuploidy, the trisomies, 21, 18, and 13. And I'll get to the point that you actually can't tell if a mom is carrying a baby that has an extra whole chromosome 21 or has a translocation or a change so that that 21 is attached to a different chromosome that gives a patient a different recurrence risk for another pregnancy. Recurrence risks for things like straight trisomies is about 1%. You can test for some of these sex chromosome aneuploidies because X and Y you can test with this disorder, though they're not really that good at it yet. Some labs will also say, do you want microdeletion testing? And we'll talk about that a little bit in a few minutes, which is testing for these very specific disorders where a very small piece of DNA is missing, causing these defined genetic syndromes, most of which are pretty rare. And then some labs add on these other trisomies at the bottom here, 9, 16, and 22. And, you know, a lot of this is about lab competition. We can do more. Those disorders all miscarry, you know, so you can decide how much you think that's important to know about. But this is kind of what you're faced with screening for aneuploidy right now. I want to spend a minute talking about why we screen for Down syndrome, because that's probably the most important genetic disorder that we screen for in general, not always, but in general, severe disorders caused by trisomies like trisomy 13 and 18. Most of them spontaneously miscarry. This isn't a big, this is a distressing situation, but not necessarily a big long-term life health burden for families. I still hear the term Mongolism every so often, which is really not very appropriate. So that's why I love this slide of the boy on the left who is of Asian ancestry, who has Down syndrome, and his brother. You can tell that there is some familial characteristics to this boy, but that he clearly has Down syndrome with certain findings that are very specific for Down syndrome. When I talk about Down syndrome to families, I don't talk about sort of the surgical corrective lesions that much because most of them are pretty mild and very fixable. I talk about sort of lifetime expectations for a child with Down syndrome, including the median life expectancy in an industrialized country of almost 60 years. Things like risks for Alzheimer's. We think that the gene for Alzheimer's is probably on chromosome 21, or at least one finding. And that these are common findings that are associated with children with Down syndrome. They're not mostly particularly serious things, but they're health issues that families sort of have to deal with. So when we talk about screening, screening was really designed for Down syndrome because that's about long-term health care issues for children. Counseling families about the risk of having a child with Down syndrome, I use a table like this because it's just easy for me to remember. And I usually, in my population, use this age 30 to 40 risk that at term, at delivery, having a baby with Down syndrome, you have about a 1 in 1,000 risk just by your age alone. At 40, that risk is about 10 times higher. It's about 1 in 10. And at 35, the term risk is about 1 in 365. For those of you who've heard the 1 in 270 number for that's a mid-trimester risk for Down syndrome. Which is about the time of amniocentesis, and about a third of those children miscarry between the mid-trimester and delivery. So these are the numbers I use. You can see how much the risk increases as a woman ages. And that's because her eggs are pretty stationary. Sperm turn over a lot. Eggs are kind of formed before you're born. That's what risks look like. But still at 40, your risk is 1%. It's not super high for all this noise and bother about all these genetic tests, right? All these genetic screening tests. This June, so this just came out, our organization, the American College of OBGYN, loosened its stance on screening with cell-free DNA and said, instead of just being able to use it in older women or high-risk women, that anybody can have cell-free DNA screening. And insurance companies are starting to get on board with that case, but that it shouldn't be used for things like multiple gestations, and it shouldn't be used to test for microdeletions. So multiple gestations is a problem because, again, we can't tell the baby from the mom. We also can't tell one baby from each other. So screening twins, there's one paper that has 7 twins in it that the test worked for. That's really not enough data to use. Microdeletions we'll talk about in a minute. If you have a screen positive test with cell-free DNA testing, so you get a test that comes back at high risk for Down syndrome, that's not good enough for a patient to make a decision that's irreversible, like termination, or we don't think that's reasonable because it's a screening test, right? Again, it lumps women into a higher or low-risk population. It doesn't tell you for sure, and there are lots of cases, and I'll talk about those in a minute, about people who've terminated a positive cell-free test without confirmation. The test might not be right, and we don't think that's appropriate. The other reason to do confirmation is we don't know what kind of Down syndrome this is. So is it an inherited kind where someone will have up to a 10% risk for recurrence, or a non-inherited kind where the risk is probably about 1%? And that makes a big difference, I think, for families and other family members. There are also some people who send that it was first or second trimester blood tests for serum screening with a cell-free test, and we think that's redundant and a waste of medical dollars. So here's some take-home issues about using cell-free testing. It's still most effective in high-risk women. I'm going to go over that in a second. It takes about a week to get a result back. It's most accurate for Down syndrome. It's less accurate for trisomy 13 and 18, which are the standard things that it screens for. Right, not much information really available on twins, or certainly nothing more than higher order than twins, but twins. In this study that came out of Albert Einstein in New York, this was a study of patients who underwent cell-free screening over a 6-month period when the test first came out, essentially. So this is 2014 reporting. They had 356 high-risk results. For the people that confirmed a true positive, 51% were really truly positive or truly had a baby with Down syndrome or another trisomy. But about 6% of people terminated without confirmatory testing. And when you see how many false positives there are, that's a tragedy because, it's a screening test. So having a positive test does not mean that the baby's affected. It just means you're in a high-risk group, even with a test this good. Using this test in younger women means that there are going to be more false positives. That's because there'll be a lower positive predictive value. I'll show you what that looks like. Also, you're not going to get any other information about the pregnancy. And in a woman who's younger, her risk for Down syndrome is much lower, but she still has risks for a failed placenta or preeclampsia and other things, which you get out of actually the serum analyte screening. So we prefer using analyte screening in younger women, but the dirty little secret here is a lot of women want this test because they get to find out the sex of their baby at 10 weeks, even when they're 22 years old. So it's not going to be as good, and I'm going to show you in a minute kind of what we say to families who want that testing when they're very young. The positive predictive value, if you're younger, is not very good. So what does that really mean? Positive predictive value means the percent of positive tests that are actually real. And that's based on how good the test is, the sensitivity of the test, but also the prevalence in the population. So if you're younger, the prevalence is much lower, and it makes your positive predictive value not very good. And here, I'll show you what it looks like. So you can see on the right what happens with positive predictive value. So at age 25 years, your positive predictive value is 33% for this test. And at age 40 years, your positive predictive value is 87% for this test. So the chance that you're going to get a true positive test result is much better if you're older than if you're younger. And having a false positive is really distressing for families, right? I mean, you have this high risk for Down syndrome. We have to kind of work it up and figure it out. And then a lot of times patients still are not convinced that their baby's okay. There'll be a lot of other there's a much bigger burden for families when you start doing testing like this with a low prevalence in younger women. The test just isn't as good. So you can do it, but you should understand what it means to do it. And remember, it's a screening test. So we're screening healthy, normal women with essentially normal pregnancies to put them in a higher or low risk category. If you have a baby like this that has a, if I could use this, I would. Here we go. So you can see this baby on the, in this picture, right? And here's the nuchal translucency that goes around the baby. So this is a big cystic hygroma around the back of the baby. That puts this baby already not in a low-risk category. This baby has about a 50% risk for aneuploidy. So cell-free DNA testing is not the right test for them. We would offer them a chorionic villus sampling or amniocentesis because she's not low risk anymore, right? And sure, there's lots of doctors who can't do those tests who say, well, we'll do cell-free first and see what it is. But the test isn't really designed for people like that. And that incurs a lot of cost because then the person gets referred to somebody else and they have a diagnostic test. So I think the take-home here is it's a test to be used on healthy, low-risk women who have normal-looking fetuses. And again, a baby like this, not normal. What do you do with a screen-positive test? You confirm it. And we talked about this a little bit already, that you want to confirm it, mostly to know if the test is right, but also to know about recurrence risk for the family. Is this something sporadic or is this something inherited? And the test really can't distinguish that. It can just say there's an extra piece of chromosome 21 in there or chromosome 18 in there, but it can't really tell you anything else. We're going to talk a little bit about reasons for a false positive and a false negative test now, so you know what to do when the results come back. So false positive test can be because you've had what's called a vanishing twin. So some people start a pregnancy with 2 babies in there and they lose one that they either see or they don't see because they had an early first trimester ultrasound. And those babies are usually chromosomally or oftentimes chromosomally abnormal. And so that DNA is still floating around in there, right? So you can get a positive test back that's high risk for Down syndrome when the live fetus is perfectly normal, but the dead fetus is still spewing these fragments. And so you really can't tell the difference. So if somebody has a dead twin in there or an empty sac in there, this isn't a great test for them because we can't tell the difference. Sometimes you get a false positive result because that's part of the built into the test failure. We'll talk about maternal malignancies, which is a really important and I think really the most valuable way to use this test that will be out there in the future very soon. And placental mosaicism. So remember I said that you start with one cell that breaks off, it develops the fetus and it breaks off to develop the placenta. Sometimes you get what's called a post-zygotic change just in the placenta, and the cells in the placenta aren't all normal. Some are normal and some are not. So, but the baby's fine. Well, what do you do when the test result comes back? We can't tell if it's the placenta or the baby. So again, it's not a perfect test yet. It's a good test, but you have to understand its limitations too, I think. The issue about sex chromosome aneuploidy is the test result could be the mother. So women, as they age, lose X chromosomes in their cells. So if you have a 45-year-old woman and she does a cell-free test and she gets a result back that's 45X, well, we don't know if that's the mother's result or the baby's result. And we've had lots of families where moms are older, they get the test back, the baby looks like a girl on ultrasound, as it should, and it's the mom that's got the 45X result, and she's perfectly normal. So that's another limitation of the test. We can't tell the difference, and in much older moms, there's a possibility certainly of getting a 45X result in those women that's really the mom, not the baby. And doesn't affect the mom, right? And then there's the problem of what do you do when the test fails? Because that is actually a really important issue with a test like this. So the test can fail because it's sent too early. So if you send it before 10 weeks, you may not get enough material to get a result, and the test will come back as a test failure. So we do encourage women to get screened so that you know you have a singleton pregnancy, that it's alive, that there isn't an empty sac in there, but you also know the gestational dating. Send it after 10 weeks. If the mom is really heavy, the test will fail. And that's another, we'll talk about that in a minute, but moms over 350 pounds have a 50% failure rate with this test. And that's because the fetal fraction, the amount of fetal cells in there, is kind of diluted in this bigger pool. But if the test fails, those patients also have a much higher risk for chromosome problems. So it becomes harder to sort that out. We'll talk about that in a second. And so that is called a fetal fraction. And fetal fraction is the amount of fetal DNA over the total DNA in there, the percent that's actually fetal. And since we know that that's about 10% of the total, labs need a certain threshold in order to read out a result from the test. So the higher the fetal fraction, the easier it is to get a result. So if you do the test at 7 weeks, you're very likely to get a failure. If you do the test at 20 weeks, you're very likely to get a result, right? Because you've got a lot more cell-free DNA floating around as the pregnancy gets bigger, and the placenta kind of sloughs off more pieces as the pregnancy moves on. If you get a very low fetal fraction or the results aren't obtained, they say the test is a test failure. I think the take-home here is that in at least one study, and remember the test is very new, that gives you about a 20% risk for aneuploidy. So I'll show you what that looks like. So this is a very famous paper that came out in 2014 where there were 100,000-ish cell-free DNA samples, 8% failed, and 22% of those were aneuploid. So there's something about having a pregnancy that's chromosomally abnormal that we think changes the placenta so it doesn't shed as much stuff into the maternal bloodstream, and it's harder to get a result. So if you have a test failure, we think those women are in a high-risk group and should be offered diagnostic testing because there seems on multiple occasions recurrent literature that says, yeah, those people are in a very high-risk group, actually. And if you're heavy, you have a 50% failure rate. And the problem with that is we don't know what to do with those test results. Is it the woman's weight, which is a very hard thing to talk about in the first place, or is it that she now has a high risk for aneuploidy? And if you repeat the test, now you're taking that out another week. So is that reasonable? In my office, we generally offer patients that are 350 pounds or more conventional serum analyte screening for a lot of reasons. One is you'll get a result. Number two, heavier women have a much higher risk for spina bifida, which you're not testing for with cell-free DNA testing, and you can't really do ultrasounds to really look at the baby very well. So at least with a conventional serum screen, you get an alpha-fetoprotein test that we can evaluate and see if the woman has a risk for an open spina bifida a little better. Cell-free DNA is not going to tell you that. And that's even correcting for folic acid fortification, right, in flour. So there's a big study out of North Carolina that showed that women who are overweight, even after flour fortification with folic acid, still have a higher risk for spina bifida. So in my practice, we actually don't use cell-free DNA testing in very heavy women because we know the failure rate is quite high. So what do? The test fails, right? You get a indeterminate or test failure back from the laboratory. Well, you make sure about the patient's weight. You make sure you've got the right gestational dating. You consider repeat testing. So again, that will put you out another week if you want to repeat the test. You can offer them diagnostic testing. You can say the test failed. Do you want an amnio or CVS now? Because we think you're now in a high-risk group for aneuploidy. And we don't think you're a candidate for serum screening now. So you had a test failure, why don't you just have a quad test? Well, we don't think that's a great idea because now they're in a really high-risk group, so we're not sure how to calculate what quad test result because they've already failed testing. High-risk group screening isn't really the option for patients like this anymore. So I said I'd get back to what other tests you can send with a cell-free sample. And one of the new buzzwords for cell-free testing is microdeletion screening. So some labs will offer you the option for your patients to do microdeletion screening. And a microdeletion is just a small segment of chromosome material that's missing that's too small to be seen by conventional cytogenetics. So you don't see it on those nice pictures of chromosomes because it's smaller than one of those little bands on the chromosomes. The thing about microdeletions is they're not associated with how old a woman is, like Down syndrome. They have a very variable phenotype. Some people are perfectly normal with the microdeletion syndrome, and they may not have ultrasound findings. So that's why they've been a big buzzword for a lot of labs to sort of integrate into their testing strategy. Send microdeletions for your patients. The standard microdeletion panels that they use are the top 5. One lab does all 8 of these. And I can tell you that these disorders are super rare. I bet you've never heard of most of them, except for probably the 22q deletion syndrome, which is, has an incidence of about 1 in 4,000 newborns. These things are really, really rare. 22q, again, has a very wide range of phenotypes, has some heart defects and learning disabilities associated with them. Most are new in a pregnancy, some are inherited from parents. And sometimes, again, when you get a test result back, it might be the mom's test result and not the baby's. So you have to be sort of prepared for test results that come back where actually it's not the fetus at all. You actually have a result on the mom. These are ways that they're offered. Not at all, opt in, opt out, cost more, doesn't cost anything. Some labs don't offer them. Most organizations, at the end of the story is most organizations say, don't do them. ACOG says, don't do them. The European Society and the American Society of Human Genetics say, don't do them. There's just no validation data on how good these tests are and who you're testing. And one day this will be a very powerful thing to do, but remember this test is really in its infancy, so we're not big fans of doing this right now. Okay, so I think this is the most interesting and sexy stuff about cell-free DNA screening now, which is the unintended things that you find out from doing a test like this. And I think this stuff is really important. We've talked about the 45Xs may be the mom. The microdeletions might be the mom. Beware the patient with an organ transplant. If you've had an organ transplant from a man, the test result is always going to be male, even if you're carrying a female fetus, right? So that's just something to think about for patients who are getting cell-free testing. They don't know where their transplant came from, but that renal kidney, that new kidney they've got is from a man, and so they're going to have a female, they're going to have a male result every time. So that's always something to sort of keep in the back of your mind. But now, to date, there have been about 26 cases of maternal cancer diagnoses from cell-free testing, which is, I think, really where this test is going, and actually where it will probably be the most useful. So look at this. This is a case report from 2013 of a woman who was 37 years old, was offered cell-free screening, and had a trisomy 13 result. She had it twice. She had it once, then she had it again. She had a perfectly normal-looking baby on ultrasound, and understand, trisomy 13 has very characteristic findings on ultrasound. Anybody could see them. Polydactyly, extra fingers, midline defects, bad hard defects, small baby. Baby looks perfectly normal. Mom has an amnio. Perfectly normal. And so the group that did this said, well, maybe this is a sample switch, or it's just in the placenta, it's not really the baby. I don't know, the baby seems perfectly normal. She had a diagnostic test that is perfectly normal. She delivers a male fetus, no problems, 3,000 grams at term, no problems. And in the hospital, postpartum, had pretty bad hip pain and got x-rayed and has cancer. And the trisomy 13 is her, and it's in her malignancy. And what she had was a small cell carcinoma of vaginal origin that had already spread. So remember, the test can't tell mom to baby, but it also can't tell if you've got some other aneuploidy going on in your body. And this was the first case report that we knew about, and that's, 2 years ago. So remember, this test is really in its infancy. So look at this. This just came out in June of this year. This is a group that from the oncology version of JAMA that said, well, they looked at 4,000 cell-free tests. This is in, I think, the Netherlands or Scandinavia. And 3 women had weird results, and they were sent for whole-body MRIs, and they had 3 different forms of malignancy. So I think in the long run, the big application of this test will be very likely to be following women who've had cancer, who've been treated, who are doing well, to see if they have a recurrence. Because if you can characterize what the aneuploidy is in in the malignancy that the patient has, doing a blood test every 6 months or a year before you do an MRI or a PET scan or something else to follow them for a recurrence, this is going to be a much more sensitive test. And I think actually that will be a much more useful application of this test than just straightforward aneuploidy screening. And remember when we talked about Dennis Lowe in the first place, that's what he was doing with this in the first place. So I think that's where we're going with a test like this. So some limitations of cell-free screening just in general. Right now, it's limited to 3 common aneuploidies and sex chromosome results. It doesn't screen for spina bifida, so we offer patients AFP screening even if they have cell-free testing. It can't tell you about translocations. And as I said, it can't distinguish the mom from the baby. It can't tell you about mosaicism in the placenta. It's still a test that really feels like it's a good test, but it's really in its infancy. And of course, the other important issues are, what does the test cost your patient? So that really depends on your insurance contracts. And every insurer is different about a test like this. So my genetic counselors, I have 4 of them. They spend a tremendous amount of time figuring out how to offer screening to patients in the most economical way. And of course, a lot of people who are pregnant now have a $5,000 deductible, so nothing's covered, right? So figuring out how to send this test in the most economical way is also really important, and it's not that inexpensive. And often conventional screening, which is really a pretty good test, right? 90% detection rate for Down syndrome, it's still a pretty good test. No, it won't tell you the sex of your baby at 10 weeks. But if you're really talking about aneuploidy screening and this test is going to cost you $1,000, maybe this isn't the way to go. Maybe this isn't how you want to spend your money. Just to summarize, cell-free is the best available screening test around in high-risk women. It's not so great in young women because of the low positive predictive value. You have a lot more false positive tests in that population. A positive test still needs a confirmatory test. A screen negative test is usually reassuring, but it's not diagnostic, so you're still going to miss some patients. Not as many as with conventional screening, but you'll still miss some patients too. And then some additional cautions. Don't send it under 10 weeks. Make sure there isn't an empty sac. Older mothers have this risk for Turner syndrome. Watch for organ transplants and watch for women who are very heavy because the test is much more likely to fail and then we don't know what to do with the test result. Is it aneuploidy or is it just maternal weight? And then I think it's important to step back and say, why are we doing these things? Well, we're really doing them to get more information for the family about the pregnancy and to help plan and educate families about their pregnancy. So if we know a baby has Down syndrome, we're going to want to make sure the baby's heart is really carefully looked at. That we look at the baby in the 3rd trimester to see if they have a bowel obstruction, because that changes where they deliver, so the baby, isn't eating after birth and can have surgery right away. We do it so that we're prepared and so families are prepared. And sometimes that really affects management. I put these things down there they're on your thumb drive, of course. But this is the ACOG statement on cell-free screening. The National Society of Genetic Counselors has a really great, and ACOG worked with them on this too, but they did all of it really. Very good information that's non-biased for both healthcare providers and for patients to talk. It's a question and answer kind of format to talk about why you use these tests and how good these tests are. And of course, it's unbiased because it's not coming from a commercial laboratory. And we all worry about conflict of interest when stuff comes from a commercial laboratory. So I encourage you, if you're in any state where you would be using these kind of tests, to look at those links and download some of that information and use it for your patients and not have it come from one of these companies. And I think, yeah, that's my last slide. Thank you. Yeah, oh, thanks, Beth. Do you guys have any questions for me? Mm-hmm. Yeah, because I think it gets recorded here or something, right?
Yes.
Thank you.
Is cell-free DNA testing another name would be chromosome microarray?
No, actually. Maybe I should be talking about that too. Thank you for saying that. A chromosome microarray, so a cell-free DNA test is a fragment, right, that's studied and counted to give you these very limited, yes or no, extra aneuploidy, big pieces of chromosome material. A microarray is a it's a very small. It's a way to look at very small pieces of chromosome material to try to make diagnosis of things. So, at least in the OB literature, if you have a baby with abnormalities, you'll probably get a result, if you do a standard karyotype, about 20% of the time and actually have a diagnosis. If you add microarray, which is a much finer look at the chromosome material, that adds about another 6% at this point. So it's a more careful look at the actual chromosomes for more genetic syndromes other than just whole chromosomes where you get big pieces. So a microarray wouldn't be something that you would use for standard aneuploidy screening. You'd use it for a more in-depth look at either a child that has findings that are often not conventional or prenatal diagnosis where you are seeing abnormalities on ultrasound and you can't actually put your name on it. So we'd send a microarray for that. And a microarray will also pick up conventional trisomies or extra chromosomes, but it'll pick up more fine details too. Yes, sir.
So remind me, you said one of the papers quoted the false positive rate being as 10% for the cell-free DNA.
Well, actually, I didn't say that because nobody knows what the false positive rate is.
Okay.
Because there's no studies that kind of look at outcomes at all. They're all from labs, right?
Oh, okay. So there is. Okay. I thought one of the papers. Okay. So we don't know the false positive. Is that what
We
you're saying?
don't know the false positive rate exactly.
Okay. So my question is: so every case which initial screening is positive, you need to go to chorionic villus samples or amnio, which now you have to tell the family is an invasive test, right? So and in your opinion, most of the parents are okay with doing that. Because in practice, I find sometimes we are told this screen was positive and nothing was done. And we've done, as a neonatologist, testing, and it's different. So I was wondering, is it standard that most parents would agree for confirmatory testing, in your opinion?
So I think if you get a positive test back, the first thing that we'll do in a high-risk office is scan the baby and look for things. So for Down syndrome, with ultrasound, you can only pick up about 50% of the cases. Ultrasound's not that great, but sometimes it helps you, right? We'll sort of lay it out for the family. We'll say, we can repeat your test. That will take another week. And we don't know if you fail once what the likelihood is that the test will fail the second time. We know that if you're really heavy, it's going to fail. But we actually don't know that much about the test to know. We can't give them a number for how well the test will do the second time. And we'll offer them diagnostic testing. And I think that's really up to families. Like some families are like, I'm never doing that. Some families are like, I have to do that. There's a bunch of families, at least in my community, that are very paralyzed by the risk for miscarriage from one of these tests. And so a lot of times they'll do like a 32-week amnio because they want the information before the baby's born, but worst comes to worst, they'll have a preterm birth, right? And even those are very rare. We think the risk for loss from amnio is super low nowadays. But I think that's, again, it's like whatever values the person brings to the table. Sometimes a lot of people just, they wanted to know what kind of baby they're having, a girl or boy at 10 weeks, and now they're down this road that's a mess when all they wanted was fetal sex, right? So there's no way to predict what somebody will do, I think.
So the take home, I guess, I know sometimes we are told, from our obstetric colleagues, we've done the cell-free DNA, we've got the answer, and that's it. So, so there's going to be some cases, I know, as what you're saying, there will be some cases that test, unless we do the confirmatory, it's going to, it can be 100%.
Right, it's not enough. If you have a failed test, that's not enough. You're not finished, right?
Sure.
Some patients will say, I'm finished, but it's not, I think, correct to just say, okay, great, sorry you had a failed test. Because their risk for aneuploidy is 20%, at least for the data that we have. So they're high risk no matter what.
Sure.
Yeah.
You mentioned the positive predictive value of the test is less in young.
Yes.
Can you comment why the young versus old? I mean, is it circulatory fragments are higher in the young?
No, it's just statistics. So if the prevalence is lower, so at 30, right, your prevalence of Down syndrome is about 1 in 1,000. If the prevalence is lower, the test just doesn't perform as well. It's just statistics. So it's pretty easy to do the math, right?
But you
And
also
say,
mentioned that the false positives are much higher in young, right?
right.
So that basically challenges the clinical validity in applying anything in the genetic testing there. I mean, in the young, something is circulating more compared to older. And why and what is circulating and why it is creating a problem in the genetic testing.
Well, if the prevalence of the test is lower or the sensitivity isn't as good, the sensitivity is pretty good, but because the prevalence is lower, just statistically, you're going to get more false positives. The test overcorrects for those. So it's not a function of the cell-free DNA test itself. It's a function of what the statistics will do to your answers. So if you've got a 22-year-old, it's not going to be a great test for them because, A, their risk is really low, and the false positive rate is going to be much higher in those people than if you're 40. So, you know, it's a lot of anxiety for a very expensive test that they probably don't need, right?
Can it be related with something more prolific in the young, such as, you know, it is definitely, there are good indications that it can be applied for malignancies, indicating that something is really prolific and then
Right.
DNA components are circulating much higher in the young because of a much more prolific tissue environment.
Well, see, we don't know that really. I mean, remember, this test has only been out for about 4 years, and it's sort of whatever commercial labs want to release to the public for us to evaluate. There's no objective evaluation of any of these tests. It's just what labs will tell you. So we're kind of stuck with that, and they don't collaborate, right? So we actually don't know anything about long-term outcomes, or no one's ever followed these, you know, there's no studies where they say, okay, we're going to look at every baby and see what happens. I mean, it's just not available. So, you know, you're kind of left with whatever these labs will release to the public. And that's a problem, because that's imperfect information, right? And it's with people with a lot of conflict of interest. Not that they're not doing a good job. I'm sorry?
What is the FDA positions on this?
Well, I'm looking over there. The FDA is very interested in getting very involved with how labs develop tests, something called the laboratory developed testing sort of bucket of the world. And that's sort of good and it's bad. You know, you do kind of want more oversight, but we're not sure they're the right group to do it. And it also means if you have some new, fantastic new test going on, and it has to go through like years of FDA evaluation, then it'll never get out to circulation to really help people. So there's like a yin-yang of that too. But the NIH never funded a cell-free DNA sort of independent trial. And I think, you know, there's only so much funding around now. So that's what we're going to be left with, is this sort of problem of what do you do when only labs that are interested in getting their money back release information about tests. I'm not down on the labs. I mean, they need to make a living too. But it's the first time we've ever been faced with that, I think. And we have to rely on what they tell you. So, hey.
Hi, my question is regarding the false negative. Let's say you tell the mom everything is fine, everything is normal,
Right.
and then you have a baby with a problem. What are the chances of that?
Well,
Of a
see,
false negative result?
Okay.
That you tell everything is good, and then at the end, you have a 45-year-old mother with a baby who has some chromosomal problems.
Okay. So I would refer you to that there was a very inflammatory article in the Boston Globe about a year ago, like last summer, I think, about all these women who, you know, had a negative test and they had a baby with Down syndrome, or they didn't have a baby with Down syndrome, but they were told they were at high risk. I mean, it's a screening test.
Mhm.
You know, it's not going to be perfect, and there are going to be some patients that screen positive with a normal baby, and some patients that are missed.
What
right?
is the number? That was my question.
I don't think
there's a
anyone
number?
knows.
We don't know. Okay.
There's no objective assessment of these things. Nobody knows. And it will change by how old you are, right? Because the prevalence will change by how old you are.
And my other question is,
It will be low, though, right? I mean, that's why the test is pretty powerful. The false negative rate for the test is pretty low. It's just not zero. It's a screening test. And it's never going to be as good as putting a needle inside because it's the placenta, and that's just not going to be as good as testing the baby.
And in the future, for this kind of testing, what applications in oncology? Do you know anything about that? Because that would be interesting to see, if we can use these testings for screening of pancreatic cancer, ovarian cancers, those cancers who are silent, but when you diagnose them, poof, they're already too advanced.
Well, I think that is a really powerful and really important thing, right? If you can find those fragments before you can see a mass inside of somebody, I think that's the future of this test. I mean, for aneuploidy screening, it's a wide application for a lot of people, but wouldn't that be powerful? And you can see it happening now, right? I mean, I think that's really the most interesting way the test is going. But new, it's all very new. I mean, it's been out 4 years, so we're playing catch up too.
Thank you.
Sure, my pleasure.
I have a mother who delivered a twin.
Can you talk into the microphone? I'm sorry, I can't hear you. You have a what?
I have a mother who delivered a twin, a girl and a boy.
Yeah.
And I see that your presentation, it's not good for multiple pregnancy, that the screening, the cfDNA. And one baby is, the girl is trisomy 21,
Okay.
and the boy is a normal.
Uh-huh.
And what test can you offer to the parents like that? Like the mother is a 28-year-old.
So you mean prenatally for twins?
Yes.
So I think twins, even conventional serum screening, twins are very difficult because, first of all, 2/3 of them are not identical, 1/3 of them are identical. That becomes hard to separate too with screening tests because you get one risk back, right? You get if you do twins with conventional screening like a quad test or cell-free DNA, you're going to get one risk result back. So what does that mean? You have 2 babies in there, and in your situation, right?
Yes.
I'm embarrassed to tell you this, but I'll tell you anyway. One of my genetic counselors sent cell-free DNA testing on triplets. She's new. I'm like, what? And it came back high risk for Down syndrome, and I was like, oh my God, what am I going to do with that? And basically, she just helped a lab get some new test information. They should have given this lady's money back. So I talked to the patient, and the babies look normal, so it's like 10 weeks. Babies look normal. I did a CVS on all 3 babies because they were chorionic, right? They're all different, all genetic makeup, and one of them had Down syndrome. What does that mean?
I know.
I don't know what it means, and I'm surprised they even reported it at a risk for triplets. They have no real data for triplets. So to answer your question, there is no good answer for multiples. No, I think if you've got multiples, you are always at a lower risk for diagnosis because ultrasounds are harder and test results are more difficult. So the American College of OBGYN says, well, probably nuchal translucencies aren't a bad idea because you can look at the fluid in the back of the baby's neck and at least have specific information for each baby because otherwise we don't have anything that's related specifically to each baby. And I think tell them that there are limits to screening, that we can't screen you that well because that's the truth. And offer them diagnostic testing if they want it. And you'll see I use the term diagnostic testing. We're trying to get away from the term invasive testing like CVS or amnio as invasive because it sounds so mean, right? It sounds so sinister. We use diagnostic testing now. So if you really want to know the genetic makeup of each baby, you have to do a diagnostic test for them. And you can look at their nuchal measurements. But you can't really do one of these tests because we can't tell the difference between these babies. People do them, but you're just not sure what to do with the results, right?
Is it higher in vitro?
That's a really good question. I think nobody knows. There's certainly a smaller but higher risk for genetic syndromes in patients that have had infertility treatments, but not for things, as far as we can tell, for things like Down syndrome. It is clear that when you do genetic screening, pre-implantation genetic screening, where they look to see how many chromosomes are in there before they put the embryos in, that really doesn't work at all, and isn't a good way to sort of remove your risk for aneuploidy.
One last question. First of all, I think it's amazing if we think about it that this test was not available 5 years ago, and how quickly this test has come into common clinical usage is pretty amazing. My question is, for those women that have opted for cell-free testing, is there the recommendation for alpha-fetoprotein serum screen to look for spina bifida or ultrasound? Because cell-free would not be able to detect that.
Yeah. Is it done? Not so much. I think in most women, if they're getting a good ultrasound, they're probably equivalent tests. In certainly obese women, we absolutely think they should have an MSAFP because it's a better test. But the other thing is AFPs tell you other things about a pregnancy too, like pregnancy failure and risk for stillbirth and stuff. So yes, we do. We offer it to everybody, just like we do for chorionic villus sampling. That's true. Okay, thank you.
Thank you. Before we let you go,
Oh my.
before we let you go, we have a small thank you for your visit with us, and I'm going to share this and show it to the guys. And this is just a small thank you for joining us at this conference.
Thanks.
So, Dr. Rose, thank you very much.